Good afternoon, everyone.
Hello, good afternoon, Dr. Maurice. We have a few more minutes. Just
Okay.
Oh, hello, everybody. Glad to see you.
Hey, Dr. O.
Can we wait a few minutes for a few more people to join us, and we'll get started. Is our speaker here? I don't see him on the Dr. Fang. Or, or, or-
No, I don't think so.
uh-huh.
Maybe somebody can.
Erdell,
Okay. I'll check. I'll
Okay,
email.
all right.
okay, thank you.
Yeah, I'll be right back.
Sure.
Okay.
Mm. Dr. Fang,
Yes, yeah, yeah.
Oh, there you are, Tian Feng. Okay.
Yeah. Could I
Yeah.
have
How
the,
are you? Good
I'm
to
good.
see you.
Could I have the Zoom link?
I'm sorry.
Could I have the Zoom link? Let me see.
I just emailed it to you like 5 seconds ago.
Yeah, I can scan the QR code, but I don't have the I wanted to share. Let me see.
Yeah, I just emailed it to you like I said just a while ago.
Yeah, could you email me the Zoom link?
Yes, sir.
Okay, 1 minute. Let me see. I cannot see the Zoom link.
Okay,
Well,
I'll put it in
we
the
have
chat.
you on, so it's okay. You're on the call.
Yeah, I'll put in the chat as well, so you can get it that way.
Uh-huh.
Okay, let me see the Zoom. Okay, let me see the Zoom link.
Okay. Mhm.
Okay.
Mhm.
Zoom link.
Did you get it in the
Yeah, yeah.
Okay.
Choose.
Okay. Our it's already 4:04 p.m.
Okay.
Can we get started?
Yeah.
Okay.
Yeah.
Well, let me welcome everybody to this next in our series on Gen AI. And we are very pleased for our guest speaker today, Dr. Tianfeng Li from the College of Pharmacy, who is going to speak today about machine learning prediction of cardiovascular emergency department visits and revisits using patient-reported data. This is a very interesting part of our series, especially dealing with healthcare and healthcare management. And so I'm very, very pleased to turn this over then to Dr. Tianfeng Li. Are you, I think you have the ability to share your screen. Okay, there you go.
Yeah, can you see my screen?
There, yeah, we see it.
Okay, that's great. Hello, everyone. I'm very glad to be invited by Dr. Arno to make a presentation about the topic. And in this research, we are using machine learning models to predict emergency room visit and rate hospital admission and readmission due to cardiovascular disease. And in this research, I'm cooperating with Dr. Sarah Bosbaum and Aris Korea and Dr. Carlos in the computer science of the female. And in this research, we use the online survey to get the information about the patients. And these patients have the cardiovascular disease, and we get the data. The survey online through Facebook and clinics and community pharmacies. And in research, we are trying to predict whether the patients have the or this survey data, I do that online by ourselves. We try to predict the ED visit and revisit and hospitalization, admission, and readmission. In this research, we use each machine learning model like model, support vector classify, live base, adaptive boosting, and reinforced gradient boosting, in dream gradient boosting actually with these 8 models. And to make our models of research more robust, during the research, we use tenfold cross-validation strategy. And we do this, we get this survey and from July 2022 until December 2022. And for this research, and we submit the data set into training set and test set, and 80% for training set and 20% for test set. After we do that, and then with the multi-category encoding and always handling to do the data processing. And next, we do the feature collection. To do the features collection, we use multiple measures to do the feature selection, like the filter method, Pearson correlation, and variation evaluation factor. And we also use the record method, including the step forward selection, backward and elimination, and recursive feature elimination. And we also use the embedded method. We use this multiple method to do the to finish the feature selection process. After that, we shall use the smart method to balance the data set, because in our data set, the data is imbalanced. For example, even in our emergency department with survey data, we have 85 patients who don't have the emergency department visit, and we have 453 patients who have the emergency department visit. That means that in this research, the patients who have the emergency department visit and who don't have the emergency department visit, data is imbalanced, and then we use the smart method to balance data set. After that, we use this 8 machine learning algorithms to first we do the we tune the hyperparameters, and then we do the at the same time use the k-fold configuration. After that, we use the model, and we evaluate the model performance, and then we report. We use the shape feature importance method to identify the factors that are affecting the outcome variable. And we use this multiple metrics, accuracy, and sensitivity, specificity, precision, and everyone score. We use this metrics to measure the model performance. Here you can see this is our emergency department visit, and we can see we have this information about the hospitalization, admission, and we also have the information about the emergency department Revists, and we have the hospitalization, admission information about the patients. And after we do that, we tune the parameters for the models, and we can see that here we have the 4 outcome variables for the emergency department visit, and for the emergency department visit, for the hospital admission, for the hospital readmission. We can see that here the red bar, the green, the blue bar measure the performance for the models before we tune the parameters. And the red bars measure the performance of the models after we tune the parameters. So we can see for these four outcome variables, we can see almost for each model, after we tune the parameters, the performance of the models, after we tune the parameters, they have higher performance than the performance without tuning the parameters. That's why it's very important for the to tune the parameters. And then after we tune the parameters, we use the IUC score to measure the performance for these models for the four outcome variables. We can see here for this emergency department list, we know that ET actual trace model had a much higher performance than other models. You can see AC score is 0.933. That's for the emergency department visit. And for the emergency department revisit, the performance is 0.997. That's for the emergency department revisit. And similarly, and for the hospital admission, each actual trace have higher performance than other performance. But by contrast, for the hospital readmission, random forest had higher performance than other models. And then after we do that, we use the confusion matrix to compare the performance accuracy. We can see that, for example, for the emergency department visit, and we can see for the 00, we can see this is the prediction for the 0, that no emergency visit, and here you can see the 600. This is for the emergency department visit. Here you can see that for this model, we can see it had a higher accuracy performance for the accuracy for confusion matrix. Similarly, we have the better performance for the actual trace in the case of emergency department revisit. And here we similarly we have the similar result for the situation of hospital admission, and we also, but here we can see for the hospital readmission, we have better performance for the actual trace. How do we do that? And then we shall use the multiple metrics to measure the performance. We can see here, even for this four situation, and then we use accuracy, precision, recall, MYC core, and AUC 5 metrics to measure the performance of these models. You can see that for this emergency department list, actual trace had a higher performance than other models. Similarly, for the hospital admission, high performance measured by these 5 metrics. And for the emergency department visit, we can see actual trace had high performance on the IUC and IUC. And finally, we can see for the hospital readmission, we can see for Revists had high performance than other models based on this matrix. And then finally, we choose actual trace for the emergency visit and actual trace for the hospital admission, and actual trace for the Revist, and random forest for the hospital readmission. And then we need to here we shall mention that in this research we need to calculate the definition of the features and how we measure them. In this research, we consider we have medication goal, medication use, medication timing, medication in complexity, medication delivery in complexity, medication side effects, medication advice, medication confidence poor, medication confidence improved, medication remember. And for this variable, because in research, in part research, researchers may only focus on the search determinants of the patients. They may also focus on the clinical factors for the patients. But in part, we don't have too much research to consider the search determinants, the clinical factors. And in here, we also consider the medication literacy factors, and we also consider medication self-efficacy factors. And here, for these other two types of factors, we use these factors, these features, to measure how these factors affect our outcome variables. And we shall mention that for this variable, we use the 5-point Likert scale. For example, strong disagree, we code it as 1, and somewhat disagree, we code it as 2, and so on. And finally, for the strong agree, we code it as 5. This is how we coded these features. And then let me do the same analysis to compare emergency department visit and emergency department revist. Even we see that, we can see for these two outcome variables, for the emergency visit or emergency visit, we can see that for these two outcome variables, they may have the similar risk factors. But we can see that for different situation, for different outcome variable, the relative importance of these factors are different. For example, we do see that for the heart disease, we can see both of them are the top factor affecting the other outcome variable. But for other variables, for example, for the we need to consider the insurance type the patient have. In research, you consider three types of the insurance, like the private insurance, public insurance like Medicaid and Medicare insurance, and other insurance. We can see that here, for other insurance, this type, for this outcome variable, it has no influence on outcome variable. But here, in the revisit, emergency revisit, it has a higher relative importance. In other way, even see the job status, whether the patient has a job or not. We can see for the department visit, the job status don't have too much influence on the outcome variable. But for the job status, it has much higher influence on the emergency visit. And then we can see that for other variables, you can see for the medications, for the visit, it had a higher impact on the outcome variable, but in the revisit, it had a lower on the outcome variable. So from this graph, we know that even the patients face the similar factors, but for different outcome variable, the similar risk factors may have different impact on the outcome variable. And let's see hospital admission, you can see that they also have the same risk factors, but we can see that for the hospital admission, for example, you can see medication company pool. Here you can see the high performance, then the admission, but here is lower, right? And then let me see. Here is new performance impact, and then we can hear different. So that means that it's very important for the patients, for the clinicians, and even for the government. How can we help reduce the risk for the patients to have hospital admission and readmission, emergency visit and re-emergency visit? And then we can see here, we want to get the how the single feature affect outcome variable. Here we can see for this heart disease, when the patient have the heart disease and it have a higher risk to have the emergency visit. And we also see that for the female, in the patient female, it has lower risk of the emergency visit. And there are other information. For example, for the home medications, your patients take more multiple medication at home, and you will have a higher probability to have the emergency visit. Let me see. You can see here. You can see for the heart disease, for the medications, for the blood pressure, and for the medication side effects, for diabetes, and for the smoking status. All these factors will increase the risk of the emergency department visit. And for others, we can see it has no probability to have to see the emergency visit. And here we can see for the revisit, they have different. For example, for the medical, we have increase the risk to have the emergency revisit. And for the medication side effects, it will also increase the risk to revisit the emergency visit. And then we can see here for the impact of the factors for the emergency visit. And now we see the hospital admission. We can see for heart disease, home medications, blood pressure, and diabetes, smoking status, and medication in capacity will increase the likelihood of the hospital admission. And for other factors, we can see they will decrease the likelihood of the hospital admission. Similarly, and for the readmission, we can heart disease, home medications, and cholesterol, and smoking status. And for other factors, we have these factors could help decrease the likelihood of the hospital readmission. And now we see the double feature dependence. Why we need to see the double feature dependence? Because in the reality, the patients are not only affected by the single feature, they may be affected by the multiple features in the same time. For example, we can see for this one, for medication side effects, and when the patients know the medication side effects, and also it has clear patient goal, and the likelihood for them to have the emergency visit will increase. And we also consider diabetes and home medications. Even if the patients have diabetes and they take more medication at home, and these patients will have a higher likelihood to have the emergency visit. But even we consider other factors, for example, when the patient knows how to use the medication, and when the patient knows take the medications, and reduce their likelihood to have the emergency visit. And similarly, and even we consider the medication use and the medication side effects, and then will help you reduce the likelihood of the emergency visit. And now we see, similarly, you can see the revisit because we know how the features affect outcome variable. Another for the hospital admission, this is how these factors decrease the likelihood of the hospital admission. And then we see real admission, we can see these factors decrease the likelihood of the real admission. So then the research we can about the how to explore what factors are affecting the patients to have the emergency visits and revisit to have the emergency to hospital admission and real admission. That's all. Do you have any questions or comments?
Are you are you done, Dr. Lee? Is this the end?
Yeah, this is the end, yes.
Oh, okay. All right. Well, so where is the floor is open for questions. So
Yes, yeah.
okay. Well, this was really great, very high level research. And so can you, because for some of us, we may have lost at one point, we may have lost the track. Can you tell us what in generally was the conclusion here of this, that whole thing?
See, for the research, we know that so first we know that the patients are affected by the multiple factors like serum determinants and the clinical factors and the medication literacy and the medication self-efficacy. Or these types of factors will affect the outcome variable. For this research, we know that even, for example, for the hospital admission, for the hospital readmission, even for the similar factors, they may have different impact, relative impact on the outcome variable. This is core information. And we also get information, for example, for the visit and revisit. We recommend how the clinicians and patients pay attention to the factors that affect their whether they have the emergency visit or revisit.
Okay. Did you publish this? Has this been published already?
Yeah, for this paper, actually, because we have too much information here, and right now, at the beginning, we try to submit the paper to one journal together, and finally submitted in two papers, and now one paper is almost accepted. And we have another paper, and we are send out the paper in 1 week or so out. The full paper about the hospital admission and readmission it almost accepted by the BMJ.
Dr. Batista, Dr. Hello. Any?
Yeah. So any other questions from the participants? Do we have other questions?
I was wondering about what this data is.
Okay.
Can you
Yeah.
talk about the data?
Yeah. We get the survey data online.
What's the name of the data?
We get the data online by ourselves. No, not from other clinical centers. Yeah.
Oh, can you, because the sound is a little bit breaking, can you send us some links or something like as an example to look at that? Maybe if you have them now, that's okay. If not, you can send them later on. So let's say so for example, from the National Institutes of Health or any, I mean, I'm not really aware of many sources for those. So those are public domains that you used, Dr. Lee?
We use online survey by ourselves. Yeah, we do the survey by ourselves, not other national or state level or any clinical center data.
Oh,
Yeah. These are some data set.
okay.
So this was a primary data collection? You collected the data from patients?
Yeah. Our research team collected data, yes.
And what was the representation like in the data for different groups?
You mean the information about the different more information about the data about the patients?
On the patients, because one of the things about AI algorithms is it doesn't predict. We wanted the results to be bias free, and for that you require underlying representative data on all groups that are affected by this condition. So was there any kind of bias analysis done on at the time of data collection, and to what extent your algorithms are robust in the sense that the results apply to all the different groups similarly?
Yes, because this is online, the patient reported the data. We need to identify the potential bias made by the patients. For example, we need to for example, use whether the patients have the similar IP, and then we identify whether the patients have intentionally misreported data by mistake, and we'll try to exclude this situation. And we also when we collect the data, we did find that some patients may not report the data. Some of them, if the data, if one survey data miss a lot information, and we will exclude the information from our collected data.
Dr. Lee, did you say you say like you have multi-categorical classification here? I guess what is such a much representation from 0 compared with 1? How you distribute all the factors for imbalance data?
Oh, yeah, here we look at yeah, we have the embedding data, and we use the we use the smooth method to balance the data set, SMOT method to balance the data set. That's one important step to reduce the bias, because whenever we use the machine learning to address the embedded data set, whether it's a binary variable or the multi-categorical variable, it's very important for us to balance the outcome variable. Yeah.
So 0 is for those who visit?
Here there is for in this case, you can see zero is zero is revist, not revist. And one means that has a revist for this case. And we also have another case, you can see for this hospitalization, zero means no hospital automation, and one means has hospital automation. And we also have other information. You can see, let me see other. You can see we have the hospital reautomation. Zero means reautomation, and one means has reautomation. So here I need to clarify how do we measure, for example, how do we measure the hospital reautomation? For example, you look at the information about the patients, whether you have the hospital automation and the patients and how many times they have the automation, hospital automation, and then you put a 0, 1, 2, 3, or more than 3. So here, when the automation is 0, and we put it at 0. When the readmission number is not 0, 1, and 1, 2, 2, 3, 3, 4, and then we could use them as well. So for this type of variable, we could use as well. And how do we reproduce the reproduction if the for example, have 0, 2, 3, 4. And then for the patients who reported 0 and 1, we put it at 0. For the patient who reported 2, 3, 4, and we put it as well. So for these patients, survey data, this is the way how we put the hospital automation, hospital reautomation, 0 and 1.
So following up on that question, it doesn't tell you the intensity. So if someone is more sick, there could be have 2 visit, 3 visit. So I just wonder if you can, how do your results, let's say, are similar to Poisson regression, for example, which is used for count data modeling. How are the AI algorithm models results similar or different to Poisson regression or regression using negative binomial, which takes into account the skewness of the data? Or are you thinking of comparing your results to other statistical regression models?
Yeah, we can consider that because we are now use the machine learning model here, and then we also use the logic regression model. And the reason for the to use that because here we use the shape analysis method. We can know what factors has a really more important has a higher relative importance on the outcome variable, but we don't know the specific variable. For example, even at the same time we can use the logical regression model. In this model, you can measure how much the impact of the factor on the outcome variable. We can use that because we know some research use this method to use the shape and logistic regression model together to give us more information. And in the same time, because this data set is online, it kind of cross-sectional data set, so we can see immediately. And you have the research, you have a data set on, you have the data set, for example, have the information about the patients for 1 or 5 years, and then we can information to measure whether in this process, in this given period, whether the patients will have more likelihood to go to the emergency visit. We have a lot of research, yeah.
Okay. Any other questions? Well, thank you. I really want to take this opportunity to thank you, Dr. Lee, for, oh, wait a minute. I think there's something in the chat here. Oh, okay. Okay. Yeah, no questions. Okay. So thank you so much for the presentation. I really appreciate the participants joining us, and we really appreciate your having the opportunity to hear you, Dr. Lee. Thank you so much.
Thank you. Thank you for your invitation.
Have a great day,
Yeah.
everybody.
Okay.
Thank you.
Mhm.